Liz, thank you so much for joining us on the You're Not Alone podcast today. I'm excited to have you on. And when I was preparing for this episode, it was just kind of bringing a smile to my face going through. And I know we were joking about this before, just everything that you've done and accomplished. And it does come from this deep place of compassion. And I was refreshing myself even on your personal story, which I want to talk about today. And it's just really cool to see how you've manifested from your own experience to wanting to help others and what you've turned that into. And so I want to give you the floor here and just kind of give that quick introduction on yourself to the audience.
Yeah, no, well, thank you, Zach. Thank you for having me. And, same to you. To watch your journey and to see where you're at now has been incredible and fun for me to get to witness from afar, and always excited to be able to work with you and collaborate. Because I think at the end of the day, our missions are very similar. I think for me, I had an opportunity to I always talk about turning your pain into purpose, right? But I had an opportunity to take my challenges and struggles and really make it my life mission. And that is something that I'm really grateful for, because I know a lot of people may not have that same opportunity, right? Or do we always have that same mindset? I can promise you, when I was first diagnosed and in the throes of my struggle, there's no way I could have been convinced that anything good would have come out of it, or that there was any reason that made sense for me needing to go through this. And, I was diagnosed at 12 with obsessive compulsive disorder. And while I grew up here in Houston, which has an amazing med center, there was very limited resources back then. That was well over 20 years ago, 20 plus. And we really didn't know what the acronym OCD stood for in my family, but we certainly didn't know what treatment would work or what treatment even looked like or was supposed to look like. And so the journey to care was pretty difficult. And in that time, my suffering just increased, which is across the board what we know, right? Mental health that goes untreated is going to get worse. And so I ended up going to inpatient treatment when I was 15. I relapsed later, went back to inpatient again at 17. And really, therapy for me is something that has become, a lifestyle, a habit, healthy habit. It's not something that it was one and done. And I think when I was young, I didn't understand that, right? So early on, I kind of resisted this whole having to live with a diagnosis and having what would it be like to learn to have ERP and these tools I learned as part of my lifestyle. I kind of wanted to go to treatment and just be done with treatment, but then things would creep back up. And so now over the years and far into adulthood, I now run an OCD program. I'm a clinician in the field, and I do a ton of advocacy and mental health nonprofit work that I'm very proud of. But what I've learned is, how can you not just take your story and turn it into good, but also how can you make your mental health journey something that can actually become a healthy part of your lifestyle and journey every day of your life, so that it allows you to manage versus suffering.
You just touched on so many nuggets, and I'm pulling out a note card here because I'm going to have to definitely jot things down as you bring them up, because you're a wealth of knowledge. And there are so many things, even from your story, when I was listening to your story again and kind of refreshing myself, that it made me realize that in addition to being that clinician, you are very much so an advocate. And so one thing that I was kind of hoping that you could talk about with my audience is kind of what your experience was like in inpatient treatment, because I know that oftentimes is even more heavily stigmatized than just hey, let's go to therapy. That I think is becoming a little bit more and more accepted, I think, in society. But inpatient, I think, still has this big stigma around it. Can you talk a little bit about what that process was like, and just what your experience with it was like?
100%. I think that it was terrifying. It was scary, especially before I got there. I didn't know what to expect. And I think I was expecting that I was just going to be checked into this inpatient hospital. And really what it was a specialized OCD program, right? That's actually what I help run and operate here at McClean Houston now. And it is certainly not necessarily this sterile hospital setting that I was going to. But even if I was going to a sterile hospital setting, it would be because I needed it. Right. So when individuals need to go inpatient because their safety is at risk, while that may not be a fun experience, or it may not feel the same as going to a luxury hotel on the beach, right? it gives us a chance at being able to stay safe and being able to live our life one day. And so I want us to quit looking at like, what's this experience going to be like, or how scary is this today or tomorrow, and to think about what this could mean for our future, right? If it's the difference in life and death, if it's the difference in being able to have freedom from our illness versus suffering, the facility itself may or may not matter as much. Now, of course, there's good and not great facilities, right? We know that. But so it was what I needed at the time, right? I had tried outpatient care. It wasn't enough. My OCD was just way too severe to be treated on that level. And so that was the level of care that I needed. And really that's what we should be thinking about is, what is our diagnosis? What is the effective treatment for our diagnosis? And what level of care do we need to see the best success or to have the best chance of success? And so, it was scary, but it was crazy at the same time of how much it became my home and the people there became my family members. And by the time I left treatment, I remember crying just as hard as the day I arrived, because I was actually terrified to leave this place that had saved my life and given me a chance again at being able to function and have independence that I didn't know I would ever get back.
Yeah. And I do remember you kind of in your story talking about at your sort of your lowest moments, right? It was like 5 to 6 hours in the shower with your mom yanking you out of there because of the intrusive thoughts and then the rituals that you were performing to try to relieve that distress that you were feeling from those thoughts. And you brought up the word severity. And I think that that's really important for people that might be in the throes of struggling with intrusive thoughts, and maybe they're right at the start of their journey. I can picture myself right now in Raleigh as it feels like my brain health is unraveling. I guess from your perspective, when is it severe? When is it reaching that level where it's like, we need to keep you safe and inpatient makes the most sense in this moment?
Yeah. I mean, I think we really want to look at functioning. Okay. Right. So somebody who is going to school, like I was 15 at the time. So if I had been able to go to school, maintain friendships, and my parents weren't worried about my safety, I don't know that I would have needed that level of care, right? Maybe outpatient care could have gotten me to the place where I needed to be. Now, granted, I do want to back up for a second that part of the reason outpatient care didn't help me is that there wasn't effective outpatient care for OCD in Houston at the time. Now there is, right? And so maybe my OCD wouldn't have even progressed if we would have been able to get the appropriate care early on, right? We can certainly believe that. But so what I really want us to think about is functioning, right? A kid like me who, by the time I went to treatment, I was totally not functional. I was showering on rare occasions. It was 6 to 8 hours every single task, getting up in the morning, walking to the bathroom, right? I would get stuck. I was having to go back and forth. I was not a kid who could function to any normal degree. I was no longer going to school. I was doing homeschooling. And so I needed something more intense to help get me back on track, right? So it's kind of, I always think about it like a diet and exercise regimen, which I don't necessarily want to go into the details of those. But if you think about, if someone has a goal, depending on what your goal is, the way you're going to achieve that goal is going to look very different.
Right.
Right. If I want to be able to run a 5K, my training is going to look way different than if I want to run a marathon.
Yeah.
And so we have to kind of think about, what are the needs, right? If someone is suffering really severely to where normal everyday functioning, so school, work, life, friendships, ADLs, activities of daily living, showering, hygiene, whatever it might be, if that is significantly impaired, is once a week a 45-minute session going to get me where I want to be? And even if it will, do I want it to take that long? Right? That's another question. Like, we have a lot of patients who probably could get better on an outpatient level, but maybe it's going to take 6 months. And they're like, I'd rather come to your program and knock this out in 6 weeks. Right. And so, it's hard to say if your safety's at risk, right? So if you're feeling actively suicidal, you're having thoughts of hurting yourself, that's a different story. That requires immediate intensive treatment to stabilize that, because we never want to wait on anything that involves safety.
Okay. And I love that terminology, ADLs. And I think that I'm circling that on my end, because I feel like that is definitely a good indication when the activities of daily life, showering, brushing your teeth, getting ready for the day, trying to get out the door to go do school, work, whatever it is that you were talking about. I love how you touched on all those categories. If those are starting to become impaired, probably a good sign like, hey, this is really starting to impact my daily life. And I know that you talk about value-based living all the time, and I want to get into that here in a second, as well as outpatient treatment. But that to me is just a really good, if you're listening right now and you're like, hey, I resonate with what Liz is saying. It took me a little bit of time to get from my bedroom just to the bathroom to brush my teeth. Maybe this is a sign. Could you just walk somebody through what maybe a day in the life of inpatient treatment would look like, just so that they can get kind of a vision, a picture of what that experience would be like?
Yeah. And there's a couple different levels of intensive treatment. So inpatient is more like hospital level. I was a minor at the time. There's residential support, which is what we have here. So it's 24-hour support that's available. And there's partial hospitalization programs, which are day programs, still very intensive, but you might go home at night if you're local and you live in an area. Most of the programs have pretty similar formatting. So it's a combination. It tends to be that treatment programming runs from about 9 a.m. to 4 p.m. for the most part every day. And it's usually about two groups, or our program, for example, is 2 groups. And then we have 4 hours of ERP. So you're actively doing treatment, actively doing exposures. And then, of course, individual behavioral therapy, family therapy are all combined in as well.
Okay. And I'm scribbling furiously on my end. People who are listening to this aren't going to be able to see this, but I want to touch on ERP and individual here in a second. But yes, so that kind of makes sense. It's a 9 to 4 structure, really focused on the ERP side, followed by some of the cognitive therapies that you were talking about. And I think it's important to mention, and I will of course talk about this in the intro, that when you're referring to your program, you're talking about the McClean OCD Institute at Houston.
That's right. Yes. So that's the program I run here in Houston. And really, we're one of, about 4 programs that specializes specifically in intensive OCD work, where residents can live on site with us. And so there's not a lot of those programs that exist. But so when I am talking about our programming, I'm talking about a program that makes sense for individuals who have a primary OCD diagnosis, right? Somebody with a primary diagnosis of borderline personality disorder or depression or substance use wouldn't make sense for them to come to our program, because really our treatment is pretty much focused on OCD specialty care.
Yes. And that is one of the questions that I had written down, because I think that you do a wonderful job of this in the times that we've partnered, and just listening to your work and how you define OCD, how you define obsessive compulsive spectrum disorder, how you break down anxiety, social anxiety, panic disorders. Can you kind of just go through how you define OCD, obsessive compulsive spectrum disorder, kind of make the differentiation there?
For sure. Yeah. So OCD is obsessive compulsive disorder. And what I want us to recognize is there's 2 main components, right? Both obsessions and compulsions that make up the disorder. The disorder is really important because a lot of times I think people think, oh, if I have an obsession, I have OCD, or if I do a compulsion, no, it needs to make up a disorder. And the way we define a disorder for OCD is more than an hour of impairment per day. So does it impact your life for about more than an hour a day where you're engaging in these different intrusive thoughts and or behaviors? The obsessions, the O of OCD, are unwanted intrusive thoughts. This is really important because a lot of people think, oh, if I have intrusive thoughts, I have OCD, or if I have thoughts, it's OCD. No, these are unwanted intrusive thoughts. So these are thoughts that bother us. They cause distress. We don't like them. They scare us, and they make us feel pretty uncomfortable, really emotionally dysregulated. The compulsions are behaviors that we do in order to alleviate the distress or get rid of the thought. So the compulsion, once again, many people have compulsions, many people have obsessions, but they can be healthy, right? If you think about a sports fanatic, right? You might obsessively think about your sports team and compulsively watch all their games, right?
Right.
But it's enjoyment, it's pleasurable, it's not necessarily distressing or problematic in your life. For people with OCD, right, the obsessions, they're unwanted, we don't like them, they don't bring us pleasure, which is a big difference. And the compulsions, again, we don't enjoy the compulsions. We do them because we feel like we have to. And we do them in an effort to get rid of the intensity and the anxiety that comes with those thoughts. What's really important to note is that these compulsions with OCD can be both internal or external. So it could be an external compulsion like a hand wash, going in and out through a doorway, engaging in checking behaviors, but it can also be what we call a mental ritual. So it could be something like saying a prayer, thinking a neutralizing color, ruminating to try to solve something that we're anxious or worried about. And that's really important because a lot of people with OCD will say, oh, well, I have only obsessions, right? Purely obsessional OCD. And then they'll talk about, well, I do have behaviors that I do that reinforce the obsessions, but they're mental behaviors. We need to identify those mental behaviors as compulsions because that allows us to better understand how to treat these individuals. We can't ignore the compulsions in the treatment cycle.
And this is exactly why I wanted to ask this question, because you do such a good job of explaining it and simplifying it. And when you were talking about the obsessions and compulsions, I related so much too to those internal compulsions, because that's really where I find myself ruminating and trying to solve those problems in my head and even doing checking in my head. So in line with the obsessions and the compulsions, can you give an example? And I loved your example of like, some of us we do have obsessions that feel good to us, right? Yeah. That sports fanatic, such a good example. And they are compulsively watching their team play. I just think that people can picture that perfectly. What are some of the unwanted intrusive thoughts that people can have? Maybe somebody's listening. Yeah. Trying to connect those dots.
Yeah. And they can range, right? So it's important to note that intrusive thoughts can be a spectrum on various different issues, concerns. And it's important to note that they shift. Most of us with OCD don't have the same intrusive thoughts our whole life, right? Our OCD will shift. We might address those ones and new ones pop up. But it often falls in categories or domains. And what we find is that it tends to attack the things that are most important to us or that are a big part of our values or who we are. So this might be, maybe we have sexual intrusive thoughts that really go against our understanding of ourselves and who we are and who we want to be. Maybe we're dealing with contamination intrusive thoughts, and the contamination fears might be fears around us getting sick and dying. It might be a fear around getting someone else sick and causing harm to someone we love. We could have harm intrusive thoughts. These can be violent intrusive thoughts. These can be thoughts that we're afraid we're going to cause harm to someone we love or to someone else. We could have scrupulosity, which is the religious form of OCD. So these are a lot of thoughts that would center around, they may center around things like, am I doing things the way God wants me to? Am I being moral? Am I being immoral? Have I done something wrong? Could God be upset with me? And there's really a lot of different domains when we look at OCD. The domains often revolve around like hyper responsibility. Do we feel responsible to make sure something doesn't happen? Some of the domains might include, like I said, harm to others, harm to self, checking behaviors. And again, those checking behaviors, if someone's checking the doorknob, continuously, is it just, I just need to check the doorknob? Or is it go deeper, which is the fears, if I don't check the doorknob, something bad might happen, right? And so it can come in all different forms, all different fashions. OCD can impact almost anything in our life that's important to us, and it tends to do just that.
Yeah. And I remember in your story, like you talking about how you would like text and call your mom and say like, hey, I need you to let me know, like when you get to the top of the stairs for lunch, that you let me know that
are you safe? You name it.
That you got there safe. And so is that an example of a compulsion?
Totally. Yeah. So the thought would be, is my mom okay? Is she safe? Right. And then the compulsion is any sort of behavior you do to try to mitigate that thought. Right. So, getting reassurance from her. If I'm afraid, I don't know if I locked the door, the compulsion might be checking to make sure I did lock the door. If I have a fear of if I offended God, the compulsion might be saying a prayer or touching my Bible or doing some sort of behavior that kind of undoes or neutralizes that scary obsession or intrusive thought.
Okay. Yeah, that makes a lot of sense to me. And it's all in an attempt to relieve that distress.
That's right.
I'm curious. I want to talk a little bit about ERP now, because I know that that's really something that you advocate for, and I appreciate that so much. Can you, for the first time listener that's hearing that acronym, can you explain to them what ERP is, sort of what that treatment looks like, and talk a little bit about its effectiveness?
Totally. So ERP is exposure with response prevention. And the concept of it is exactly what it sounds like, which is that we expose you to the things you're afraid of or that you find yourself avoiding or ritualizing around. Right. So maybe expose yourself to touching that doorknob that feels contaminated. And we do response prevention, which means we ask you to not engage in the response that your OCD wants you to engage in. So to not engage in that compulsion, right? So touching that doorknob and not washing your hands, if that's the typical ritual that you do after. The big thing with ERP is, are we doing ERP in a sense that we're both doing exposures and response prevention and we're actually addressing the fears, right? The core fears that exist.
Right.
Or are we just doing response prevention to kind of extinguish that one fear? And so what I mean by that is, I could touch my doorknob and not wash my hands. And if I keep doing that repeatedly and I touch other things and I don't try to like keep my hands isolated, that doorknob will no longer be scary, right? I will extinguish the fear of that doorknob being contaminated. But if I have contamination OCD around lots of different, say, doorknobs or other things, I'm going to have to go around and do ERP for all of my different, fears, all of the doorknobs. And so what we also want to make sure is that when we're doing ERP, we're not only doing it focused on ritual prevention, but that we're also targeting that core fear, right? So are you allowing that core fear to be something that you start to focus on and you start to lean into and accept uncertainty around? Because that, when we do that, right, if my core fear of the doorknob, the core fear isn't the doorknob, right? The core fear is what will happen if I touch the doorknob. So
That's
maybe it's, I'm going to get HIV. Maybe it's, I'm going to get the flu. Maybe it's, I'm going to be sick and get someone else sick, right? Whatever it is. If we target that core fear, now it also applies to lots of other things that we're avoiding. And so we don't necessarily have to address every single doorknob, every single trigger, because we're addressing some of the triggers, but we're addressing the core fear simultaneously, and those other fears will wipe away.
Yeah. And I'm glad that you're bringing that up. And I think that that's actually a really interesting point, because I was reading Deconstructing Anxiety. Have you heard of that book?
Yes.
So he talks about 5 core fears and everything that he's talking about in that book, and I don't know if you've had a chance to read it, is really around exposure, sitting in uncertainty, accepting uncertainty, which is obviously, as you and I know, very, very critical. And I want to get your perspective on that here in a second. But he was talking about there are basically 5 core fears. I remember 4 out of the 5. It's fear of death being one. And I think you touching on, like, underneath, even like a deeper layer underneath, even just like that fear of getting HIV, one might argue is like, you're fearful of getting HIV because you're fearful of death, is what he
could be. It could also be fear of causing death to others. So sometimes it's like, I'm not afraid of getting HIV, but if I get it then from a doorknob, then that also means I could give it to other people. And so the core fear could be causing harm to others.
Right. Yes. And he talks about that in the book too, as loss of love, losing love. And there was a few others, but I think the big idea here that I like about what you're talking about is it goes to a deeper layer. You're shooting past that surface level fear to get to that deeper level where you can address that deep rooted fear and learn how to create acceptance around that uncertainty. And I think that that's super important. And I want to understand from your perspective how important it is for somebody to develop the skill of acceptance when they are going through ERP.
It's the most critical piece. So Dr. John Grayson, who wrote Freedom from OCD, and myself are working on kind of trying to coin a new concept where we're going to call it ERP plus AU. Funny enough, AU is actually the acronym for GOLD. So we believe it's like, this is the hidden gold piece of OCD, piece of ERP treatment for OCD. But what it's about is ERP plus accepting uncertainty, right? And because what we have found, again, ERP alone works to distinguish fears. But one of the things I hear from advocates all the time is like, Liz, I feel like I'm constantly playing a game of whack-a-mole. I'll address one fear and then a new fear pops up and I have to address that one and a new fear pops up and a new fear. And what I find is that, well, let's think about why. And the reason why is because we're constantly just trying to manage our symptoms, but we're not addressing the core fear. And when we address, it's kind of like when you pull a weed. When you pull a weed and you get the root, you
Right.
know that weed's not coming back. But if the root breaks off or you just get the top piece, like it's going to come back. It might take a little bit, right? Or look okay in that moment. You get some relief that it's not sticking out, but it's not gone, right?
Yeah.
You have to get the root for it to be gone. The core fears are the
important.
root of OCD.
Yeah.
We have to address it there. We have to get to that. And that is the uncertainty piece, right? And I think a lot of people, especially lately in the field, I have found there's this like controversy between uncertainty and like people get nervous about it because I think some people have this fear that uncertainty means that like we have to accept our worst case scenario, or we, you know, why should we accept uncertainty when people without OCD don't walk around accepting uncertainty every day? My answer is like, actually they do. They just don't know that they do because it's not in their face. And guess what? One of the things John Grayson says that I love is he's like, okay, you don't walk around every time you get in your car leaning into the fact that you may become mangled and paralyzed after a car ride, right? No one needs to do that. No one wants to do that. But guess what? If you get in a car accident and you become paralyzed, you will have to deal with it, right? And you will figure out how to face it and how to deal with it. For those of us with OCD, we don't get to just live in this ignorant bliss. We wish we could, right? If we could, we wouldn't be in treatment. We're already having to face these fears. It's as if it's already happened, right? For us, that's how intense the anxiety, that's how much the fear is in our face. And so we actually do have to figure out how to deal with it because it's already there. We can't just pretend like, oh, it's not there, let's just move on. So I've been pushing a lot lately is we cannot have a suppression model when it comes to OCD. If when you have a thought and it comes up and your thing is like, I have to suppress this, I can't deal with it. Of course, that makes sense. I get why you want to do it. No one wants to deal with scary stuff. But the more we suppress things, the more they keep popping up all throughout our day and actually have more control over us than they ever will if we just stop and address them right away and just go ahead and address the root, which is the scariest part, right? In the moment, it is terrifying to go all the way in and to lean into uncertainty. But that is where freedom exists. And we're not asking people to accept their worst fear, right? One of my intrusive thoughts for a long time has been, what if I'm a pedophile? What if I do something wrong? I don't need to be okay with being a pedophile. Because guess what? That's not who I am. I'm never going to be okay with that. That would be something I would never be willing to do. But I do need to be okay when I get scary sexual intrusive thoughts with acknowledging that thought and not trying to solve it. And also not trying to suppress it, because that is uncertainty.
Yes.
And that's actually what everybody without OCD does every day of their life.
Yep.
Right? They have weird thoughts. We're not the only people with weird thoughts, but they let it just be a weird thought because they don't do anything about it. They don't try to suppress it. They don't try to solve it. Suppression with OCD or solving with OCD gets us stuck. Accepting the thought and the uncertainty that comes along with it and then choosing to move on gives us freedom.
I think that that's probably the most important thing. That we're going to clip that and put that at the front as the teaser.
Please.
It's so important. And I love that you're coining the AU, the accepting uncertainty piece, because it is the most important piece. And I remember at the start of my journey, and I'm going to ask you here in a second, how do you cultivate acceptance? But I remember at the beginning with my OCD, I just started recognizing early, like I'm playing this game of whack-a-mole, and it was like the constant boogeyman around the corner.
Yep.
And I remember like, I would be like, I don't want to watch this particular TV show because I'm afraid that something's going to be in the TV show that's going to then prompt a thought that then's going to make me start to compulse and obsess and like, I'm going to get stuck again. And I could feel my world shrinking. And I do owe a big part of my accepting uncertainty to mindfulness and meditation, which is something that I advocate for. And you and I actually presented on that, I think, a year or two ago. But I'm curious, what are some tips that you have for teaching people how to develop the skill of acceptance? So,
it's a good question, because I think that we never fully develop it. I think we're constantly learning how to utilize it. Mm-hmm. Right. So the goal of treatment is that we're willing to learn to live with uncertainty.
Right.
The goal of treatment when someone arrives day one is not that you're willing to accept uncertainty, because guess what? If you could, you wouldn't be in treatment, right? These thoughts have so much power of us. They're very distressing. But we're constantly learning. And with a new thought, it might derail us for a little bit. It might trigger us, but it's, hey, can we get back on track? And can we learn how to live with uncertainty around this fear or around this thought, compared to trying to appease OCD, which, as we know, is actually not something that's feasible, right? That's an unaccomplishable task.
Yeah.
And so the biggest thing I tell people is, really, you have no other choice.
Yeah.
And that throws most people off. They're like, well, that's not true, Liz. Like, I can be certain. No, you can't. There's not anything in life you can be certain about, right? I scheduled this 1:00 meeting with you today, long time ago, right? To get it on our calendars to record this. And while, yes, of course, I had every intention of being here, and I'm sure you did too. We had it would have been impossible for either of us to say with 100% certainty, I'll be there at 1.
Amen.
Because we don't know that, right? I can plan to, I can feel confident that I'm going to be there, but I don't know for sure. Life happens, things happen, right? That I can't control. But most people don't have to think about certainty, right? They schedule the meeting and they have no reason to believe they're not going to be there. And so I'm acting as if, oh yeah, I'm certain I'll be there, but I'm really, even in scheduling that meeting, I'm accepting a ton of uncertainty. It's just not in my face. For those of us with OCD, when we have a trigger, it's actively in our face. And what happens is OCD tries to totally fight and resist against accepting uncertainty. It wants you to be certain. But what we know for those of us with OCD is that certainty isn't achievable. And the more we try to achieve it by rituals, the more stuck we get and the bigger our OCD becomes. And so the reality is you have no choice otherwise. I always give this example to patients with bloodborne illnesses. You know, I myself was in a situation, have been in many situations where, I'm very triggered by this. And so I can remember, back in the day when I would go to the grocery store, I remember there was a time where I had groceries on the conveyor belt. Yeah. And I noticed that the cashier had a Band-Aid on her finger. And I was super triggered in that moment, right? Because I kind of felt like I had no option. And I felt like, okay, if I get these groceries, I either throw them away, but if I get them, I'm going to become cross-contaminated by touching them and by using the credit card. I could try to clean them, but that won't work. And so my only way to stay safe, keep OCD safe in that moment, was for me to say, oh, sorry, I forgot something. I'm going to go grab it. And I actually really just abandoned the groceries, right? Because I didn't want to then have to touch anything she had touched. Okay, so in the moment, it felt like for my OCD, I avoided a catastrophe. I avoided having to come into contact with someone who had potentially had blood. Had I eaten takeout that week? Probably. Had I gone to a restaurant? Most likely. Right. How did I know that none of the cooks in the back had a Band-Aid on? Right. How do I know that the stalker that actually put those groceries up that I had already touched didn't have a Band-Aid on? I didn't know that, right? And so I actually had already accepted that risk and that uncertainty without knowing. But for some reason, when I was faced with it, right, I was super triggered. But the reality is I had already accepted the uncertainty around touching things that people have touched with Band-Aids on, and I do every day. I just don't have to recognize it. But with OCD, just like that trigger, it feels like it's in our face all the time because we're having to see it. And you'll hear people with OCD, I'm sure you've said the same thing, where we'll say, I wish I didn't know that. I wish you just wouldn't have told me, right? Because now I wouldn't be triggered. And it's, when you think about it, you're like, how funny, right? But so it's that, right? When you think about it, you're like, okay, that's so illogical that if I didn't know, even if the same thing happened, then I wouldn't feel scared. But I'm only scared because I know. Our risk hasn't changed, right? And so again, uncertainty is something you have to accept as a part of life.
I love everything that you're saying because I just agree to the fullest extent. And when I started to deploy what you're talking about, and this is one thing that I'm sure that you can resonate with too. I don't like getting this message, but I get this message a lot from people, which is, how, Zach, do I get rid of all of my intrusive thoughts like you? And I'm like, whoa, time out. We need to run this back real quick. Yeah. And I'm like, number one, the goal is never to get rid of the intrusive thoughts, because the moment that becomes your goal, you are doomed.
you're trapped. And it's not feasible, right? They did a study years ago where they looked at people with OCD and people without OCD. They had them record their intrusive thoughts, and the clinicians were going to separate. These are the people with OCD. These are the people without. And guess what? They couldn't do it.
Right.
Because everyone has intrusive thoughts, OCD or not. Intrusive thoughts we all have.
Exactly. And so Dr. Irene Wagner was who treated me down in North Carolina when I was in Raleigh. And that was one thing that she taught me right off the bat. And like, it brings a lot of comfort too, because you're like, all right, every human being has intrusive thoughts. Now it's just me learning how to change my relationship with the thoughts. And that's what I always talk about. And that's what you're talking about with accepting uncertainty. You're changing the way that you relate to these thoughts. So I always tell people when they message me, like, I could have had many intrusive thoughts today. The difference is I don't really remember, because when they came into my brain, I was like, oh, there you are. Hi, how are you doing? Like, hope you're doing well. And then I went about my day. Now, of course, I want to preface, this came with a lot of ERP work in advance. Like, I've put in the work just like you have, hours upon hours of, at the beginning, just agonizing. And, I don't want to turn people away, but ERP can feel a little scary at the beginning. Totally. But at a certain point, it's like, because of what you're talking about, accepting uncertainty, I don't know. I do still have intrusive thoughts, but I just don't care, because I've built up this acceptance tolerance, I guess you could say, to them. And one thing that Dr. Irene taught me was this like, maybe I am, maybe I'm not. Maybe this will happen. Maybe it won't. Like, you brought up the car example. I remember, like, when OCD was trying to morph, like, I would sit in my car and I would be hit with these images of, like, me getting into a terrible accident and hurting somebody, or me getting extremely hurt, getting paralyzed. That was one that I would have, or that I would slip walking up the stairs and, like, hit my neck and become paralyzed. And I would just repeat to myself over and over again, yeah, maybe this will happen. Maybe this won't happen. And I would kind of shrug my shoulders and then go through the action. Or maybe I would have. And I think it feels scary for people without OCD. It's scarier actually sometimes for people without OCD, because they'll say, like, but why does someone have to lean into the uncertainty that this could happen? Right. And, and again, because you do it anyways. Right. Exactly. So I always give the example of, if you're driving down the road, people with and without OCD have had the intrusive thought of, I could swerve off the road and kill this person. Right. If they see a pedestrian. When someone who doesn't have OCD, when they have that thought, they kind of like they might think, like, why do I have that thought? Or that was weird. Or they think nothing at all. Right. But they keep driving. Right. And as they're driving, they start thinking about their to-do list and errands they need to run and what they need to get done and their work day. And by the time they get to the office, they have zero recollection that they had that thought. Right. Doesn't mean they didn't have that thought. Right. But they don't remember it. They don't remember it unless someone reminds them or asks them, have you ever had that thought? They might think, oh yeah, I had that. Someone with OCD, if that thought is triggering, right, immediately it's, why do I have that thought? What does that mean? Do I want to hurt somebody? And then they start going down this path to try to solve it, looking in the rearview mirror, making sure they didn't hit anyone, checking their car when they get to where they were going to make sure there's no blood. And now by the time they get to work, there is nothing they can think about except that thought. The thought in and of itself isn't the issue. As you said, it's how we respond to the thought. Are we feeding our fears and making them bigger? Are we running away from our fears because we're just avoiding, right? Which makes them just as much bigger. Or are we approaching our fear? Are we letting it be there so that it can dissipate? Yeah. Every person has been at a restaurant outside with annoying birds that want to be fed. You don't get rid of the bird long-term by feeding it. Short-term, you do. You can throw that bird a cracker or a crumb, and kids often will, right, get away, and you throw it the crumb and you get that immediate relief. The bird goes and grabs the crumb. But guess what? That one tiny crumb, it doesn't matter how little it is, has taught that bird that it will get fed by you, you're its food source, and to come back for more. And when it comes back, it tells its friends, it becomes more aggressive. And now you are in a cycle where it is going to be miserable to try to get rid of that bird, that entire lunch or dinner, or whatever it might be. But if you ignore the bird, right, it's there. You can't deny that. Like, you can listen to it, see it, you can even recognize it. And you see, like, okay, the bird is there. You don't try to just get away. I don't want to look at you, right? Because you can't do that. It's annoying. It's chirping.
but you don't feed it, even though that's harder in that moment because of the distress of the noise and whatnot when you're trying to eat a meal, the bird will go away and it won't come back for more because it hasn't been fed. And so my push is, are the behaviors you're doing, are they feeding your fear or are they confronting it? Because when we confront it, even though it's harder in that moment, it's scarier, it's more intense short term, our fears go away because we're not responding as if we're scared. We're not responding in a way that we're trying to solve or understand. We're just kind of like acknowledging their presence and moving on with our life.
That was that. So that's the first time I've ever heard that analogy. And that is literally such a great analogy. And I think that it's, as somebody that once upon a time had so many pigeons flocked around the table,
that's right,
that I could barely focus on eating my meal because I was tossing so much food off to just try and get things away, birds away, and they were just coming back in. I just, such a good analogy. I'm curious, do you think COVID has had an impact on the OCD community in wanting that certainty? Do you think that COVID has had an impact on like greater society as a whole wanting certainty?
I think COVID has had tremendous impacts across the board on society as a whole, certainly on mental health, right? When you think about what do we tell people, right? Don't isolate and don't avoid people, places, and things, right? In general, for depression,
right.
What did COVID teach us, right? Isolate and avoid people, places, and things. So of course we saw an increase in mental health, and we're continuing to see that, and the ripple effect of it. I have seen patients OCD, especially contamination OCD, now morph towards COVID fears, right? So above and beyond normal COVID fears, but like OCD COVID fears. But that's not abnormal. We saw that with the Ebola crisis. We see that with all sorts of things that happen, right? It's kind of what's prevalent today, what's something we're focused on, and then does OCD attach to it or not? So that makes sense. Do I think across the board? I think actually what we have found is that people without OCD, for the first time, have had to have uncertainty in their face. And for some people, they've handled it well, but for majority of people, they haven't known how to respond.
Right.
And so I actually think the general community has so much to learn from the OCD community and from our treatment, because those of us that actually are managing our symptoms well or understand ERP and uncertainty very well and can apply it, we've been able to teach people without OCD quite a bit during COVID. Right? Which is, okay, you do the best you can from a safety perspective, whatever you're comfortable with, right? But outside of that, the more you try to control, the more you try to understand, the more you say things like, I have to know it's okay, or COVID has to be over. You have no control over that.
Right.
You have to learn the only way to have freedom right now around COVID is to accept the uncertainty that, like, all right, this is where we're at today. No idea where we're going to be at tomorrow, but I'll deal with that when it comes.
Right. I know. I feel like I just want to give you a mic and give you like a stage in an arena and just just have them coming in and out, just teaching people how to
address fear. Yeah.
Because that's what it is, right? We've seen this huge uptick in fear and because of the uncertainty, and we have seen the general population. Initially it was shock, and then I think it turned to sadness a little bit, because to your point, these are skills that we were forced to learn. So how my wife and I, and I'm sure you as well, have responded to COVID times has been a little bit different from what I've seen from quote unquote, the general population, and just people are riddled with fear. And I think that that's why we've seen such harsh reactions looking at it through the lens of the US specifically, because obviously it's a little bit different in every country. Right. But just almost this kind of like, it feels like a little bit like people have like kind of turned on each other at times because of that fear and that uncertainty. And if we were able to do the work internally.
And the reality is that even the people who have conflicting views, right? Oftentimes it's not about the view. It's about the fact that, like, I need to know mine's right. And I need to know yours is wrong. Right. And again, this kind of need to know and need to be certain about things that no one has certainty around. It's can we just accept the uncertainty? Can I accept that you might make different decisions around COVID than I make, than my husband makes? And that's okay.
Yeah.
And we within reason, we get to choose our own ways that we feel to keep each other safe. But what's happened is people have turned it to, if you aren't doing what I'm doing, what you're doing is wrong. Versus, okay, like you're making your choice, I'm making my choice. Let me figure out how, right. And sometimes based on people's choices, that may impact you or like decisions you make, and that's okay. But again, we have to kind of quit trying to have full control, because even when we have full control, there's not certainty. Right. I will tell you, I'm a very safe person when it comes to COVID, or I certainly was at the beginning. I've had COVID twice.
Yeah.
And everyone's like, how did you of all people get COVID? Right. Because it's like, I was going because I was super, honestly, early on, I was very triggered about what if I got COVID and brought it back to the clinic. That was my fears. I don't want to give it to someone else here and impact them, right, in a drastic way. And it happens. Right. And guess what? When it happens, you actually tend to deal with it better than the fear of it happening.
Yeah, no, of course. And I also think that that's such a testament to your heart, that the biggest fear you had wasn't getting it yourself, but getting it and giving it. And I just think that's a testament to everything that you're doing and the work that you're doing. But there's so much wisdom in what you're saying about learning to live with uncertainty, because yes, this grab and this need for control is driven by this deep down desire for survival, right? That's like what I've kind of realized in this time period. We all just want to keep living and loving, and that's such in our human nature. And I think that that's beautiful. And so we look for ways to bring self-perceived control into our lives.
Yeah.
And I get that. But to what you're saying, there's just so much wisdom and freedom in learning to accept uncertainty, the AU of the ERP and AU methodology, which I just think is such a beautiful framework that honestly should be taught everywhere. So I love that. And I just think it's super, super important. So, I was obviously looking at the McClean OCD Institute website. You were talking about treatment methods based in scientific research, evidence-based treatment protocols. You were talking about the cognitive behavioral and the medication treatment modalities. Could you touch on that aspect of treatment? Then I want you to quickly touch on therapy as a lifestyle. And then I know that you are a busy, busy woman. I want to get you back into your life. But I think that those are kind of two questions that I really was kind of itching to ask you about.
Totally. So what we know is that the most effective intervention for OCD is a combination of exposure and response prevention, which is a specific form of CBT. So that's the CBT we talk about. CBT alone will not treat OCD.
Right.
It needs to be ERP, which is the specific form, and a combination of medication. Medication can be, there's lots of different medications, but there's some that are more effective for OCD. And so oftentimes people, the first line is that they want to start with a combination of both and really get going. What we know is that no matter what, you have to be doing exposure and response prevention. So if someone is like, well, I don't know if I want to start with both, I'm going to do just medication. What we know is that you really need to do behavioral therapy. And it's not just about being able to manage your current symptoms, which it is, but what we're talking about that's way more important than treatment today is treatment as a lifestyle, which means freedom forever. Right. One of my biggest frustrations is that throughout the years, and I was one of these advocates for a long time, right? I think you may have been for a little bit. You were talking earlier that you dealt with this sometimes yourself early on in treatment, where I kind of had this resistance of accepting treatment as a lifestyle. And I really thought, okay, I can just treat right now and I'll be fine.
Right.
And then what I actually concluded, which is even worse, is I started to accept the notion that because I have OCD and I'll have OCD forever, that means I have to suffer forever. And I really believed that, like, okay, you can learn to manage your symptoms, which means it's like this constant battle every day of your life. Right. And that is doing good. And I am here, you are here, right, to push that notion that, like, absolutely not.
Right.
What a shitty job either of us would have if, like, we're going out trying to encourage people to seek treatment, if the best we could do with treatment is functioning.
Right.
Our goal is not functioning, actually. And I think a lot of people, I tell my patients this, if you're coming to treatment because your goal is, I expect, and my goal or expectation for treatment is that I can function while suffering with OCD.
Right.
That's like, we don't line up. Our treatment methodologies don't line up. The goal is freedom. from OCD.
Yes.
Which means that long term, do I still have intrusive thoughts just like you mentioned earlier? Yeah, I'm sure I have a ton, but they don't really stand out because guess what? The way I respond is very different.
Right.
Right. I have an 11-month-old and I had a sexual intrusive thought about her a few weeks ago in the morning. And it took me by surprise. Like I was pretty, had high anxiety immediately when I first had that thought, when I first woke up.
Yep.
But guess what I did? I acknowledged the thought of like, okay. And I made the choice not to solve it, not to try to understand it, because that would have gotten me stuck all day. Instead, I acknowledged the thought and I got up and I got dressed and I came into work that day. And by the time I was running group at work, I forgot I had that thought.
Right.
That is freedom from OCD.
Yes, it is.
We can't guarantee we're never going to have thoughts. We can't guarantee we're never going to have anxiety. But what I can tell you is that if we don't respond in a way that gives the thoughts power, the thoughts become powerless. And when they're powerless, we have less of them. We don't even really recognize that they're there. And OCD is not something that's disruptive to our life, right? So our goal is not functioning with OCD. Our goal is freedom from OCD. And that's the entire point of treatment. And for different people, depending on where you're at, there's different levels of care. You can engage in outpatient care, intensive outpatient, residential type of treatment, right? That's going to kind of depend on your severity level and what you need. But our goal for treatment outcomes, no matter what level of treatment you're doing, should be the same. And what I'll say as far as ERP as a lifestyle, when I talk about treatment and ERP as a lifestyle, what I don't want anyone to hear is that that means you should expect the way it is in your hardest times is how it's always going to be. Right? ERP as a lifestyle it becomes a lifestyle. Right. If you asked me, I don't run, never been a runner, but if you asked me to go run 2 miles tomorrow, I'm not going to be able to do it. And maybe I could do it, but it's going to be a run walk and it's going to be a tremendous struggle for me. Right. Because that's not what I frequently do.
Right.
But if you were to tell me, Liz, I want you to be able to run a mile by July 1st and I work up to it or run 2 miles by July 1st, by the time July 1st comes, I should have already done the 2 miles and I'm able to do it. And not only in July will running 2 miles, it won't be challenging. I also actually might kind of enjoy it. And what I tell people is that when we're in the throes of treatment, that's the hardest part. But when we're doing it as a lifestyle, it actually becomes kind of fun. In the sense that it becomes this opportunity every time we're faced with fear. It's an opportunity to say, am I going to approach my fear or am I going to run from it?
Yes.
And every time we approach it, it becomes a challenge that we actually welcome because we're not afraid of the fear anymore. We're not afraid of the thoughts. And so it's not a scary challenge we have to embark on. It's simply just like, oh yeah, this is how I live my life, right? This is a part of my lifestyle that I not only am totally capable of doing today, but I'm actually excited to be able to do.
Yes. And again, I love your analogies. The running analogy is so solid because it's just like with anything in life. And people can picture, I amazed my wife this morning. I ran 3 miles on the treadmill and she was like, how did you do that? And I was honestly like, I really don't know.
Sometimes we shock ourselves, right?
And it was definitely a run walk, but yes, it still happened. So giving myself a little pat on the back this morning, but because I do not categorize myself as a runner at all. But it is a skill that if you wanted to run, call it that marathon or whatever, you have to build up to it. It's the exact same thing with cultivating the skill of acceptance. It's the exact same thing with cultivating the skill around ERP. And I just absolutely love that because yes, it is something that when it becomes a lifestyle, and one thing that I'll say, just a little tip to drop in there for people is like, I do micro exposures as necessary. Like just in the moment, this thought comes into my head. I almost lean into it. You talk about getting competitive with it. And I like one up it. I'm like, oh, come on. That's it. I'm going to use that knife to hurt my wife. No. Come on. I want the big one. That one's really going to get the job done. Like I play the game with it because it's like, it's just once you realize how your brain functions, you fall in love with just how amazing it is that we can train our brains to lose interest in things that once terrified the hell out of us.
That's right.
And I just think that that's so cool.
And what we have to recognize is actually our behavior, our responses directly correlate to the thoughts.
Right.
And a lot of times we think we have to get rid of the thought first. And that's what treatment's all about, is actually about the fact that we do the opposite. We change the behavior or the response, and the thought goes away, decreases, right? Diminishes. That they're actually very much convoluted. And so I call this, Zach, I love what you just said. I call it ERP on the go. And I'm a huge fan of it, right? Which
Love
is that most people think, oh, ERP, I've got to have 2 hours to sit down and do ERP. No, you don't. You need 5 seconds. You need 20 seconds, because guess what? As quick as that thought comes in, you can one up it, address it, and move on. And that's important. You know, I think some people think that ERP means that, okay, you have to sit and you have to have 2 hours and you have to do these exposures. And actually, sometimes sitting and leaning into uncertainty for 2 hours is actually rumination and a ritual.
Right.
Leaning in is accepting the thought and going on and doing these things that are important to us. And what you know and I know is that the more we live our life by our values and the things that we want to be engaging in, the more we have fight to address OCD. Because guess what? When we start to do the things that are meaningful, we start to say even more reason why I'm not going to let OCD take that away from me.
Yeah.
And so go out, live by your values, lean into your thoughts, because guess what? When you try to not lean in and suppress, they chase you all day. When you try to not lean in by solving them to get freedom, you're stuck all day. Right. And so why not give it a chance of kind of acknowledging that they're there and doing the things you want to do?
So beautifully said. So beautifully said. So to end the episode and get you back into your life so that you can live by your values and get back into what you do on a day-to-day basis, what is one piece of advice that you would give someone who is right at the start of their OCD journey right now?
Same advice I would give anyone, which is that help and hope are always available. I know, and I know you know, Zach, there's been many times in our life where we couldn't have believed that. And we didn't see it. We didn't know it. And what I'm here to say is that it doesn't matter where you are. It doesn't matter how far in your struggle you are or how close to recovery you are. Help and hope always remain available for every single person.
Help and hope are always available for every single person. I think that that's so important. And Liz, I was very excited for this episode, and you just absolutely blew it out of the water. You're an expert to the fullest extent.
Well, thank you. And same to you. Thank you for everything you do. It's been incredible to watch your journey, to see you advocate. And I know so many people have related to you, and you've made such a difference in their lives.
I appreciate that. And same to you. And thank you so much for coming on to the show. And I look forward. I mean, we could have gone for hours, right? There's more conversations to be had here, but I think that this was a great starting point. And I just thank you so much for coming on to the You're Not Alone podcast.
Anytime. Looking forward to it next time, and we'll talk soon.
Okay. Sounds good, Liz. Thank you.
Bye-bye.
Bye.